Well, good afternoon, everyone. Thank you for joining us for today's webinar session. My name is Fernando, and I come with the Region 9 Head Start Association, and I will be your webinar host today. So feel free to contact me via the chat option of Zoom with any logistical questions you may have regarding audio, video, or any connection issues that you experience throughout today's session. Just a disclaimer, today's session will be recorded and will be made available for on-demand viewing after today. And you will find the recording or a copy of the recording up on our website at www.region9hsa.org. We encourage your participation, so today's presenters have prepared a few poll questions to share with you all, so please take the time to participate and share your insights with the group. If time permits, we will also allow the last 5 or so minutes at the end of the presentation for any questions or any discussion that you have sort of going on. So we'll leave that until the end of the session. In order to submit your comments and or questions, you can use the Q&A option of Zoom, which should be on your toolbar. And you can submit questions or comments with either of those tools. So now it is my pleasure to introduce our topic for today, Early Head Start Home Visiting Data-Driven Outcomes. And our speakers today are Delia Vicente, Nancy Villarreal, and Ricardo Rivera. Thank you. Take it away, Delia.
Hello, everyone, and welcome to the Early Head Start Home Visiting Outcomes webinar. And thank you for joining us today. I would like to take this opportunity to thank the Region 9 Association, of course, Ed Condon, Fernando, all staff and board members for the opportunity to share information on our efforts in documenting home-based outcomes in early Head Start. We have 3 presenters today for this webinar, and I would like to introduce you to one of them, our presenters, Ricardo Rivera.
Hello, everyone.
Go ahead, Ricardo.
No, I was just going to mention we're from Baldwin Park Unified School District. We serve 280 students in a home-based option. Most of the students are in early Head Start, and we have about 12 that we currently serve for early Head Start home-based. So we're excited to share some of what we found with you.
Thank you, Ricardo. I would also like to introduce you to another presenter today, Nancy Villarreal.
Good afternoon, everyone. My name is Nancy Villarreal from Los Angeles Education Partnership, Early Head Start, and we have a home-based program in the South Los Angeles area, and we are recently received a new grant for the community of Inglewood, and we are on the process of starting that.
Thank you, Nancy. And I am Delia Vicente. I'm the Executive Director of UCLA Early Head Start. We have 108 children in the home-based option. And the information that we're going to be presenting you today was a collaborative effort among 5 Early Head Start home-based programs in LA County, being, of course, Baldwin Park, LEP, who introduced themselves. But we also had Pediatric Therapy Network and Foothill Family, who participated in the data collection of the home-based outcomes. And so through our collaboration and each agency's effort and support, along with Region 9, we were able to document our outcomes that will lend a voice to home-based programs and hopefully begin a wave of data collection among various programs so that together we can have data that will highlight all of the wonderful work that is being done across Region 9 and across the country in home-based programs. Before we get started, I'd like to hand the presentation over to Ed, who has been a great supporter of our efforts.
Thank you, Delia, and thanks to the team for putting this wonderful paper together. The Region 9 Head Start Association is really honored to partner with you to lift up the work that you've been doing in Los Angeles County, gathering this data on such an important program option for the children and families that we serve. The paper has been posted on our website, and so let me take just a moment to share with the attendees where they can find the paper. If you go to the www.region9hsa.org hsa.org. So that's region, the numeral 9, hsa.org. Follow the tabs over to advocacy, and the very first drop down you'll see is home visiting. So again, you want to go to our website, find the tab on advocacy, then go to home visiting, and you'll find on that page the link to the paper. So again, the Region 9 Head Start Association focuses our energy on lifting up what works in Head Start, giving voice to the programs, to the projects, to the unique efforts in local communities, and we're very honored to partner with the agencies from Los Angeles, and we hope ongoing with agencies throughout the region in the years to come to continue to push the opportunities that home visiting brings to our families and our communities. Thank you, Delia.
Thank you, Ed. So for today, our agenda includes a brief discussion of the importance of documenting early Head Start outcomes for the home-based option. We're going to walk you through our journey in developing the outcomes, and we're also going to present to you data from our 5 programs as a collective. We're also going to talk to you a little bit about the data collection systems that were involved and the opportunities for you and your program to get involved in these efforts. So before we get started, I'd like to have a poll question and really ask who is out in our audience. So we're going to have a poll. If you could let us know what is your role in your program, and go ahead and click if you're a home visitor, a director, a service area manager, a home visiting supervisor, or are you in another role in your program? Okay, do we have the results? Great. So it looks like for the most part, most attendees are in another role. We have a good portion of directors and service area managers, some home visitors, and some home visiting supervisors. Welcome, everyone, and I hope that this information is going to be useful for you. Okay. At the same time, I'd like to know if you, I'm sorry, let me see. Okay, at the same time, why is this even important, and why are we collecting information? If we look at how many home-based programs we have across the nation, we have over 1,500 early Head Start programs across the nation, serving over 160,000 children. And of these children, we have about 57,221 children served in the home-based option. In Region 9, we have 200 early Head Start programs serving 26,000 children, and approximately half are in a home-based option. We know that in California, again, we have 10,000 children. In Arizona, we have 1,500 children in home-based options. In Nevada, we have 156. And in Hawaii, we have 408 children. And we see that for the most part, the data is letting us know that about half of the children are being served in a home-based option. Yet most of the research in early Head Start and most of the data available is around center-based programs. And we know that home-based programs have a large positive impact in families, as documented by family stories, individual program data, yet we do not have a lot of collective data to show our impacts. Each program, of course, has defined for themselves outcomes and measures, and we have, of course, testimonials and the stories of many, many families who have benefited from services, yet we do not have a collective home-based voice speaking the same data language, measuring the same outcomes, and showcasing everyone's amazing work as a collective early Head Start home-based voice. So the Home Visiting Early Head Start Data-Driven Outcomes Report, published by the Region 9 this month, is an attempt for us to have that collective voice. And this webinar is also an attempt for us to have that collective voice. So hopefully you will be joining us in our next data collection effort. So if we could have the second poll question. So how familiar are you with the home-based program option? Let us know if you've never heard of it, if you have some basic information, if you operate a home-based program, if you're well-versed, or if you're an expert. Okay. As we're getting the votes, can we see the results? So it looks like everyone is pretty well versed in it. So that will let us know how to continue with the presentation. So thank you for that. And it looks like everyone's heard of home-based. So that's really good. So why is it even important to collect data? Well, currently the landscape calls for evidence-based home visiting, evidence-based practices, evidence-based programming. And as such, we must engage in this data-driven world with our own early Head Start data, with measures that can speak to our practices and how these are effective. We must have data to support why it is important to continue to invest in early Head Start, and specifically, why is it important to invest in home visiting? The Head Start landscape also calls for evidence-based practices and data-driven decisions. And of course, ongoing tracking of child and family outcomes are really vital for us as programs to understand whether we are meeting our desired outcomes or whether we are not. And data collection for home-based outcomes will allow us to see if we are being effective or if we need to make some changes. Now, I know that data collection can be scary, especially if the data shows a gap, but it is better that we know so that we can fix it. And I can tell you that the hard data will only support the stories that we have of families succeeding. In addition to that, if we all have a set of common indicators, then at that point we have a collective voice that can further document the benefits of early Head Start home visiting that we can really use for advocacy and for influencing further funding for more services so that more families can get the benefit. Data makes us stronger as a program. Data makes us stronger as an organization as well. So let's begin with our journey. So our journey in home visiting outcomes began as a collective when Baldwin Park Unified School District, LEEP, Foothill Family Pediatric Therapy Network, and UCLA Early Head Start participated in a data collection pilot project in Los Angeles led by the Los Angeles County Perinatal and Early Childhood Home Visiting Consortium. This pilot was to find a common set of performance measures across a variety of home visiting program models and pilot the data collection. The concept of having a set of home visiting indicators was part of the Pew Charitable Trust home visiting campaign. They set out to develop a common set of indicators that could measure effectiveness across home visiting programs with various models such as Welcome Baby, Parents as Teachers, Healthy Families of America, Nurse-Family Partnerships, etc. And several states across the country participated in this. And LA County actually qualified due to its population size. So because LA County is so large, they actually qualified as a state to be able to participate in the Pew Home Visiting campaign. So the Home Visiting Consortium decided, though, that they would not use the Pew Charitable Organization data indicators. Instead, they used the indicators as a starting point and modify them to better suit the LA County context. And all 5 agencies were involved in this. However, we found that although documenting home visiting outcomes across home visiting models is a well-intended project, it is important to consider that each home visiting model has a unique set of goals, it has a unique set of intensity, it has a service delivery model, it has data collection methods, and a mission. And therefore, it is difficult to measure the same outcomes across models. And in addition to that, the general public can erroneously compare various program model outcomes. And I would really caution against that because each program is so unique with a goal and focus and with a certain level of intensity, and most importantly, with a specific set of data collection methods. Early Head Start, for the most part, collects data reported by the parent and verifies this using documents. So, for example, if a parent reports an income at 100% of poverty, there's an income statement that is used to verify the income. While in other programs, this might just be a self-report. In Early Head Start, when a child is said to be up to date with well-child exams, this is because this has been verified through a copy of the medical visit or a form completed. Again, while other home visiting programs may solely rely on parental self-reported data. So we felt that it would be beneficial to have our own set of outcomes in our own report. So participating in this project with the Home Visiting Consortium served as a bridge among participating early Head Start programs to begin the discussion of collecting countywide and perhaps at some point state, region, and national-wide data on home visiting outcomes. Okay, so with that, could we get poll question number 3? So how long have you yourselves been providing the home-based option? Are you considering the option? Have you been less than 1 year, between 1 and 3, or between 3 and 5, or 6 or more? As you take a minute to vote, thank you for participating. And could we get the results? So we see that a lot of you have been doing home-based for 6 years or more, almost like 77%. And some of you are considering the option, and some of you have about 14%, 3 to 5 years. Thank you for that. So within your programs, you might already have a lot of this data that we're going to talk about. So within our journey, we partnered, the 5 agencies we partnered to collect data and to subsequently report it out as a group to begin this movement of home visiting early Head Start data-driven outcomes. Before we dive into the outcomes, I'd like to take a moment to define 2 sets of measures that are commonly referred as outcomes. So first, we have a process measure. And this is really defined as the actions that programs take to promote a desired effect. So for example, when we look at our data, there are things that we do as programs to promote an outcome. So we might provide a certain number of trainings, or we might provide a certain number of screenings. These are all examples of process measures because they describe what we as a program did to promote an outcome. And then there's an outcome measure, which is the effect of what happens as a result of the program services or process measure. So an outcome often assesses the well-being of participating mothers and children in areas such as, for example, breastfeeding. So we might talk to the family about the importance of breastfeeding, and then the outcome of that would be that the mother initiates breastfeeding. Or we might provide a series of parenting classes that talk about positive discipline. And then as a result of that, we see that there are less child abuse reports and child removals. So that would be an outcome. Or we might also provide a series of trainings on strategies to cope with stress. And so we can report out a process measure saying we covered mental health in 10 home visits. And as a result of that, when we screen for depression, we see lower scores. So that's a little bit on process and outcome measures. Now we will describe the actual outcomes that we used, and Nancy will walk you through those.
Thank you, Delia. Before I start, I do want to thank my team. Data collection is scary, and I couldn't be here, without having the support of my amazing team. So thank you, everyone. The outcomes measures currently that were selected for pregnant women are breastfeeding initiation and breastfeeding at 3, 6, and 12 months, depression screening, prenatal care, 80% of the prenatal care visits, postpartum care. This is like the mother having their 6-week postpartum visit, family planning, and this started out as a birth spacing, but it's a little bit difficult for programs to collect information. Family planning is usually more feasible for families. Health insurance of pregnant mothers. It is important to consider that not all the programs are collecting all the information. It will be ideal for all of us to think about how these outcomes are or can be collected in our programs, but it's not necessarily that we're not collecting this information. We selected depression screening as the most important to report on and bring attention to. This decision was based on documented effects of depression on developmental attachment and maternal and child outcomes. We decided to focus on the outcome process measure. For children, the following are the selected outcomes indicators: the well child exams, emergency room visits, child maltreatment, infant mortality, child development screening process, that's a process, and child development referral and assessment process. Your program might not collect all the information about the ER visits, but the rest of the information is standard information for the PIR. We selected the child maltreatment and infant mortality as the most important to report and bring attention to. We have to say that they are all important and that we hope that at some point we do report them, but we are focusing on these 3 only: depression, infant mortality, and child mortality. Depression. So let's begin with the outcomes of depression. Why depression? We do not have control over outcomes of treatment, but at least we can screen, identify, and connect mothers or families to resources. The reason why we want to screen for depression is due to the well-known effects of depression. The effects of depression have been well documented, and of course, there are many levels. However, we do know that depression can influence parenting practices, influences the formation of emotional attachment. Interestingly, even mild or experimentally, maternal depressed moods have been found that they reduce the baby's responsiveness to the mother's ability to elect possible responses for their babies. In other words, if the mom is depressed, the baby will connect or will feel what the mom is feeling. So now we're going to go why depression screening and why is it important. Extensive observations of infant and toddlers of clinical depressed parents reveal that they have a difficult in regulating emotional expression, controlling aggressive impulses, and sharing and cooperating with others. The research has shown that depressed mothers talk less to their children and thus fail to promote their children's language development. One group of mothers whose questionnaire responses identified them as depressed had children of 2 years old with excess emotional and behavior disturbances as delayed expressive language development. Depression screening is a recommended indicator because home visitors have built a trusting relationship with mothers and can be better identify women who are struggling with depression, connect them to mental health services, and therefore reducing the parent's sense of isolation and improve their ability to ask for help when they are feeling overwhelmed. So, outcomes of depression screening. So we have found that we collect at least 98% of the depression screenings, and successfully found out that, so the depression screenings found out that we do serve at least 98% of all the depression screenings. 52% of the mothers of children reported enough symptoms to be diagnosed during this process. 26.1% of pregnant women self-reported depression, meaning that they have not gone to a medical entity, but they do feel that they are depressed. And 34.5% of women did not receive any social emotional support. And this were found through the screenings for depression, systems in place to provide mental health, and supportive home visits. This was the result of the assessments, and therefore we were able to connect parents or mothers to find, to receive resources.
That's right, Nancy. The data is really telling us that there is a high need in the population that we serve. There's 52% of mothers who reported enough symptoms to be diagnosed. This was a research study conducted in early Head Start families. Here in LA County, like Nancy mentioned, 26% of the pregnant women self-reported depression, and 34% did not receive emotional support. However, when we add in the factor of early Head Start, we see that early Head Start home-based programs have the ability to screen for depression. Programs have systems in place to provide mental health resources, and of course, families receive supporting home visiting. So the participating programs screened 98% of their pregnant women participants. We are, of course, in each individual program, we have data on how many of the parents screened positive for depression and then how many parents receive support. That data is not available to report out today, but the initial step is to ensure that we are screening for depression and are identifying the needed services. The second home visiting outcome that we are tackling at this point is infant mortality. And infant mortality is the death of a child before their first birthday. Infant mortality is a tragic event that no family should have to go through, yet many families do go through this unfortunate experience. The CDC, the Center for Disease Control, reports that programs can really address social, behavioral, and health risk factors in an effort to reduce the infant mortality rate, and early Head Start programs are in this amazing position to do that. Home-based programs can promote healthy behaviors, talk to parents about safe sleep, and reduce the risk of infant mortality. Early Head Start programs provide pregnancy services to support healthy pregnancies and promote prenatal care, and again, reduce the mortality rate. In addition, program services are often delivered to children prior to their first birthday, so we're in a prime position to be able to have an effect on infant mortality. The outcomes that we collectively have found is that infant mortality prevalence was lower in early Head Start than in LA County and that in California. In early Head Start programs, we had at 0.32%, which is about a 3.2 per 1,000, much lower than LA County, 4.3 per 1,000, and lower than in California, 4.5 per 1,000. So we see that early Head Start home-based programs are really making an impact in this. And so if you were to participate, then we would only increase the impact that we have in this indicator. The next outcome, child abuse, Ricardo will walk us through.
It's so exciting. Thank you, Delia. It's so exciting to see from the polls that we have so much experience today on the webinar. So obviously, a lot of what we're going to talk about is things that the individuals on the webinar already know, but it's nice to have confirmation of the great work being done out across the nation and definitely in our region. The next outcome, as Delia was saying, is child maltreatment. Being part of a home-based program, we provide services targeting prevention through our home visits, socializations, parenting classes, workshops, referrals. Part of our outcome was to lower the incidence of child abuse, right? We're striving for a low number of reports and a low number of children removed from the home. That was really the goal that we set forth. So obviously, if you look at some of the research, the prevention of child abuse was selected as another home visiting outcome. Child abuse can be potentially affect the child's development and create lifelong trauma. As a school district grantee, we see students who have been impacted in the early education ages, and then we see how that follows them through elementary, middle school, and even high school. So we definitely see the need to make sure we're making preventative measures to try to prevent the child abuse. Approximately half of the children who enter foster care show cognitive delays, language difficulties, and have lower IQs. 82% of children show disruption in attachment. However, and we know this, right, as home-based advocates, child abuse is preventable. Research also widely found that parents who face adversity with support and a combination of protective factors can show resiliency in facing serious hardships, and incidents of child abuse are reduced. So if we look again at the research, a lot of it speaks to the power of the services that we provide and what it can do to families and to communities as a whole. So child maltreatment can cause serious physical injuries and even death. Children who are abused or neglected, including those who witness domestic violence, are more likely to experience cognitive, emotional, behavioral problems, anxiety, depression, substance abuse, delinquency, difficulty in school, and early sexual activity. In addition, child maltreatment can disrupt brain and physical development, particularly when experienced in early childhood, increasing the risk for health problems in adulthood. Examples like heart disease, cancer, obesity, depression, suicide, among other items to have to deal with. Children who are abused or neglected also are more likely to repeat the cycle of violence by entering into violent relationships as teens and adults, or by abusing their own children. Beyond the impacts on individuals, child abuse has a significant impact on society. The total lifetime economic cost due to a new child maltreatment cases in a single year is estimated at $124 billion in the US. So we are talking about the possibility of being able to put in preventative measures to try to counter that issue. An estimated 702,000 US children were documented victims of maltreatment in 2014, and approximately just under 1,600 of these children died from abuse or neglect. These figures are considered underestimates, as child maltreatment is often underreported. While abuse and neglect occurs in all types of families, certain factors place children at increased risk. For example, children under age of 4, which is most of the population of our attendees today, and those with special needs are at greatest risk for maltreatment. Examples of family and community risk factors include substance abuse, mental illness, social isolation, major stress, poverty, domestic violence, and unsafe neighborhoods. Again, probably describes a lot of the communities that we currently serve. So we see the power of a home-based program within the context of what we do. So we know that children that we serve face a variety of situations that could place them at risk for child abuse. And we know that Early Head Start targets prevention by focusing on providing information on age-appropriate expectations and milestones. Early Head Start Home Base provides home visits that give the parent a platform to discuss concerns, questions, and receive the necessary support. Socialization sessions and parenting classes serve as an avenue for parents to socialize with other parents of young children, especially those that are isolated. Socializations really can be a very powerful tool because it really connects parents who otherwise may be isolated. We found that among the 5 participating agencies, and this is probably one of the more incredible figures that you'll see, 0.57% of children enrolled in the 5 Early Head Start programs were reported to DCFS, which is an incredible number, 0.57, compared to the regular population, again, being a district who has other programs and sees the difference between our home visiting families and those that don't have the home visiting program, and the higher rates of reporting for people who aren't doing home visits. And then if we look at the other figure, 0.28% of children were removed, which again, what a low number. I mean, we have a lot of students at our district that are being removed at significantly higher rates. So those participating in our Early Head Start program, home visiting program, have significantly lower numbers. Numbers that we definitely should be proud of. This is definitely a win as we look to analyze this information, since we're working with families that have a high risk of child abuse, and less than 1% were involved with DCFS while in our program. I think Delia was going to talk a little bit to you about some data collection systems.
Thank you, Ricardo. So as we look at the 3 indicators that we're highlighting today, depression screenings, we, for programs who do serve families who are, or for programs who serve pregnant women, depression screening is something standard that has to be done for pregnant women postpartum, and many programs do it too when the pregnant woman enrolls. So a lot of you already have this data, and it's just a matter of lifting it up and for all of us to report it as a collective. The second indicator being infant mortality. There is a lot of programs might not necessarily track that, but infant mortality, due to its impact and because it would be something so important that happens in your program, you would know about it if there is a child death in your agency. So that would be something fairly easy for most programs to document. And then child abuse, we are all mandated reporters, and therefore we all have data on child abuse reports. And then of course, whether the report was substantiated or unsubstantiated and whether children were removed. Those are things that a lot of the programs have already. So the outcome measures that we are collectively reporting on today is something that your program has data on. What we found when we participated in the pilot, and even when we did our collection for this report, is that many of us were able to retrieve the data from either our electronic tracking, from reviewing the files, from reviewing health notes, from the 2-week postpartum visit of pregnant mothers, from reviewing contact notes, home visit forms, or really reviewing health intakes of children when they enrolled. Then, because we were not yet electronically tracking all of the data, we had to hand tally a lot of this information. So since we started this journey, though, many of us have transitioned into tracking this information electronically into Child Plus so that we can now readily have the information available. And of course, if you are interested in tracking the outcomes with us, you can outreach to us and use some of our modules that we have created or some of our strategies in terms of how we have tracked this in Child Plus. And I can tell you that it's as easy as adding an event. For example, in your health module, you can add an event that says depression screener and then start to track it that way. Or you can choose to track this in a family services module if you're using Child Plus, and coding it with the status So for example, for us, for child abuse reports, we created an event in the Family Services module in Child Plus, and we named it Child Abuse Report. So now when there is a child abuse report, we go ahead and enter the information there, and then we pull a report to see how many child abuse reports have been made within the last PIR year. So again, these are small tweaks to a data collection that you already have. And each outcome has also been defined by numerator and denominator. So for example, child abuse, we have said how many child abuse reports have you made? That's the numerator, and the denominator would be the total number of children enrolled in your program for that PIR year. So in order for all of us to compare the information and report it in a given year, we have taken the PIR year for each program and just reported that out, whether your PIR year begins in August or September or any other month, as long as it's that 1 year where you reported that information to the PIR, then that's what we're using as our marker so that all of our data could be comparable. So I know that, of course, every program has program goals and all programs have data, and you most likely have all the data that we just reported on, but the key here would be for all of us to report this information as a collective so that we can have an impact. If we would be able to say 166,000 children were part of this data collection, and out of those, we have 0.53% that were reported, had reports of child abuse. I mean, that is huge, right? What we're trying to achieve here is to really provide a roadmap so that we can organize our data and package it in a meaningful way that is going to have impactful reports, not only for us as individual programs, but as a early Head Start home-based community. It's really easy for each one of us to get caught up on the details of our program, but when we start to see it as a general roadmap for all of us, we can really see that we can have a huge impact and all of us be working towards a mission. Now, when we think about the outcomes and the measures, like I mentioned before, there is an opportunity for you to participate. Ricardo, would you like to share how programs can participate with us?
Yeah, absolutely. It was so exciting to see so many experienced people as we did the poll, because I think it's an opportunity. We'd love to be able to see, you hear the wonderful work we always talk about in the Head Start and early Head Start communities, how we need additional research and data and be able to show the great work we're doing to make sure that it's showing an impact. Well, now you have an avenue to do that. So we envision that this pilot, that the pilot project, which is what it is at this point, of reporting outcomes of early Head Start will entice more agencies throughout the region to join these Los Angeles County groups to report on the home visitation processes and outcomes. For those of you who are active and constantly maybe meet with your representatives in Washington or at the state level, one of the things they ask about is, what data do you have to share? So being able to expand this program beyond just LA County, even beyond just the 5 agencies that currently participate, would be incredibly powerful. We're so proud of the results reported in this report, and we know they're not unique to our program, but rather are most likely very common among all early Head Start and Head Start, because we do have some Head Start home-based programs like ours, and we would like to encourage participation from other agencies. We hope that this webinar and the report that goes along with it will further entice other programs. We do want to ask you that if you are interested, you should contact Ed Condon, who was the gentleman who was on at the very beginning. To register your agency to participate in next year's report. You can also submit a letter of intent stating that you would like to participate. This does not have to bind you in any way. It's a simple way of letting us know that you want to participate and help us keep track of who's wanting to participate. The data is analyzed as an aggregate and will not include individual data. We do have one assigned person who collects the data, and that's Delia Vicente, who's our host today. She summarizes and reports one number to the participating agencies, like you see here in the home visiting early Head Start data-driven outcomes. You'll have your own data to report as you wish.
Thank you, Ricardo. That is correct. So we see that the measures will show us immediate benefits that will be linked to healthcare services, screening for child development, screening for maternal depression. It will showcase how we are strengthening parent-child attachment. It will show how we as a program are strengthening parental capacity, and the data will link educational and employment opportunities as well. So the Home Visiting Early Head Start Data-Driven Outcomes Report is our first wave, but we hope to be able to showcase and link the other indicators, as we mentioned, to these immediate benefits. And then as a long-term, we hope to be able to show that through Early Head Start home-based services, we are making an impact in promoting healthy child development. We are lowering abuse and neglect. We're preparing children for school. We're lifting parental economic self-sufficiency and strengthening family function. And we hope to be able to have this movement, and we hope to be for you to be part of this movement as well, because of course we want to make sure that no one gets left behind. So after this webinar, it is my hope that you will begin to collect 2019-2020 data. And even if you don't feel comfortable sharing and reporting it out yet, at the very least, if you can begin to organize your data and collect it, you will have your markers so that you can also prepare these reports for yourself and your program if you so wish to. Of course, our hope is that we can collectively have a voice and be able to do this as a home-based program unit. Are there any questions? I'd like to open up the floor for any questions that anyone might have at this point. And Fernando, I will rely on you to go ahead and read off the question.
And Delia, while we're waiting for questions to come in, and this is Ed, I just wanted to first thank the three of you for an excellent webinar today and for the leadership that you've shown in this particular space. It's exciting to see the work grow organically, and certainly Region 9 hopes to continue to elevate that. For our listeners and those on the webinar, I want to encourage you also to think of the practices that are going on in your communities that Region 9 can elevate. We do webinars about every 2 months on innovative practices. If you go on our website, you'll see we've done webinars on serving families incarcerated in jail. We've done webinars on staff development and other such topics. So we're always excited to share this space with local practitioners really leading the way and raising new and innovative concepts.
Okay, so we have a question asking, do you want data from outside the region?
Absolutely. I think that we hope that at some point this becomes a national report where we're able to highlight all home visiting programs across the nation. And I do have to say that the data is an aggregate. We don't need any identifiable data. We hope to be able to have a follow-up webinar with any agencies who are interested so that we can go over the numerator and the denominator more in detail, and we can provide tips on how this is now being tracked and in some of the documents that you might find them or where we also found the data. So absolutely, I would say yes. Outside of the region, in the region, out of state, we want participation from Nevada, Hawaii, Arizona, and of course, the Pacific Islands and nationwide, yes.
Delia, and if I may, this is Ricardo. I know only because school districts, being from a school district, we tend to be extra paranoid in school districts about student data. So if anybody out there is a school district, I know we have at least one. I know El Monte is on the call. If you need help with trying to figure out how you kind of would bring that information up to an assistant superintendent or your superintendent, whoever has concerns with sharing the data, let me know. I'd absolutely be more than willing to help because I think it's such critical information. And sometimes districts are just afraid to release data. They don't fully understand how it's going to be used. And so I'd be more than happy to help you with that.
Yes, and we were really thoughtful about some of the indicators because we really wanted them to be, of course, universal, but at the same time, we wanted them to be items that are either part of your annual report or that are part of your reporting already with PIR, so that, you know, this is public information.
And also if you don't have it on your systems, you can also do it manually. We did a lot of our tally, like Delia was saying, we were counting. So if you don't have it on your system yet, it could be done manually too.
That's correct. Fernando, do we have any more questions?
Yes, thank you. So the next question is, who do we contact to get Child Plus module examples or reports you've created?
You can feel free to contact me, Delia Vicente. We have created some reports with that. I could also have a conversation with you over the phone. A lot of it is really looking at how you're wanting to do your tracking. One of the things that we did is that we didn't really want to create something separate for our team to do. As we all know, our team is often stretched. And so what we did is we looked at our current tracking system and reflected on whether that was the best way to track it. So for example, we already did the depression screeners. We already do those with pregnant women, correct? And so we would track it in a paper form in the child's file. So we switched that, and what we did is we just created a health event that said depression screener, and we entered the data was completed and the results. And then that way, we were able to pull a report by the PIR year on all the depression screeners that were completed with the results. So we didn't have to go ahead and manually track it. But in our first run of the data, we did, because we didn't have the system yet. So, you know, those are the type of things that we've done. And I'm happy to have a conversation with any of you on this. We're hoping to be able to get your letters of intent. So we'll follow up with a sample letter of intent. And then we hope to then have a webinar that will highlight all of these items as well, all of the tracking that goes along with it.
Great. There's another question for you guys, Delia. The question is, what depression screening is used?
That's a great question. So what we found was that in multiple programs, there were multiple depression screeners that were used. For example, we use the PHQ-9. Other people might use the Edinburgh, the Beck Depression Scale. So the type of screener that you use really doesn't matter. It's just conducting the screening. We did set thresholds though in terms of what would be a positive screen, and that usually went along with each scale. So we followed the rating of each scale, and that's how we determined whether it was a positive screen or not. So whatever depression screener you're using is okay, as long as those screenings are being conducted.
Excellent. So we have another one regarding the content of the presentation. Will this PowerPoint presentation be available so we can share with others in our agency? And like I mentioned at the beginning, we are recording this session, so the recording of the webinar with all of the presentation from Delia, Ricardo, and Nancy will be available for on-demand viewing. If you are referring to the actual PowerPoint presentation, I believe, Delia, we can have a copy of it and turn it into a PDF and link it to our website. Is that correct?
Yes.
Oh, perfect. So yes, we will have a copy of the PowerPoint for downloading as well as the recording. Next question we have, what was the frequency of the depression screener? Was that supported in sub-events or Child Plus?
I'm going to let each agency respond, but in my particular agency, we didn't track it in sub-events. We tracked it under the health module as a health event titled Depression Screener, and then we also recorded the score.
We also track it through the health and through the education piece. But talking now, I'm getting different ideas on how to track it individually.
Ricardo?
Yeah, our team tracked it through our mental health and health areas. So like Delia says, I think each agency has its own way of doing it. We do a lot of collaboration between our mental health team and our nurses who do a lot of the visits to the homes.
Yeah, so if you already have a way of tracking your data, you wouldn't necessarily need to switch to the way that we're tracking it. It's just a matter of being able to pull the data in an easy way so that your staff doesn't have an additional report to do. Fernando, any other questions?
Yes, we have one more question. Will we have two data sources collecting the same data? Example, the consortium and now this collaborative.
So I'm not sure how many people are still participating in the LA County Home Visiting Consortium. If you are participating in that, yes, it would be two different sets of data that you would submit, just because the consortium has one person that is probably putting the data together, and then we have me and the rest of the team who's putting the data together for the early Head Start. But I do want to say that I feel that it's important to highlight our outcomes in an early Head Start report, because I feel that we can really focus on early Head Start data.
Yes, I also want to agree with Delia. We do participate in both, and sometimes what the consortium is, categorizing a screening tool or a home visit, it's a little bit different than what the early Head Start or the Head Start, components have we tracking. So that's why for me it was important to also participate in this data collection module.
Delia, and if I may, I would confirm that same thing. We also participate in both, but I think this particular data collection is super critical for our early Head Start information. Not only for our information, but the fact that it gets rolled up with others becomes incredibly powerful. So we still participate in both, but I think there's real power to what Delia and the team is putting together.
Thank you. Any other questions, Fernando?
No, we do not have any further questions at this time.
Thank you. So with that, I really want to thank you for your attendance. And if you have any other questions, please feel free to contact us. We will follow up with you with a template letter of intent for any of you who are interested in being part of the second wave of this publication, which we hope to have ready in 2020.
Excellent. Well, I want to take the moment to thank again Delia, Nancy, and Ricardo for your time today and excellent information and presentation. Just want to remind everybody once more that this webinar session has been recorded and it will be made available up on our website at www.region9hsa.org. You will find a copy of the webinar recording as well as a PDF version of the slides today. So thanks everybody for your participation, for your attendance, and hope you have a great rest of your day. Thank you so much for your time today.
Thank you.